So we will discuss about the basic concept of Doppler. Before going to Doppler, some concept about physics of ultrasound. Ultrasound is basically a sound wave, that is, it is a mechanical longitudinal wave. That means if it is a longitudinal wave, it will have a to and fro motion of the particles. That means when sound wave moves, that means the particles have a compression and rarefaction. So because of this compression and rarefaction, that is to and fro motion of the particles, the sound wave travels. So if you draw the sound wave like this, so lambda equal to wavelength will be distance between two crests or distance between two troughs. That is the wavelength. Basically, the ultrasound machine works on the principle of pulse echo technique. So what is pulse echo technique? Now, because of this technique concept, when from a sound from an ultrasound probe, when in the ultrasound probe there is a piezoelectric crystal. This crystal basically send the beam, ultrasound wave. It will send the ultrasound wave or beam to the object. It will send the beam to the object. Now the sound wave got reflected. It gets reflected from that object. It hit the object and get reflected back to the probe. Then we get an image on the monitor. So we get an image on the monitor. Suppose this is the image, small image. So ultrasound probe send multiple sound waves. So some sound waves will hit the object and reflected back, and they will reflected back to the probe. But so some sound waves will go hit the object and reflected back to the probe. So that will be imaged in the monitor. But few sound waves, they will not hit the object, they will just pass away. So that is not reflected in the image. So the sound waves which get reflected at the object, they are reflected in the monitor like that. So in B mode we'll get a grayscale, and in M mode means motion, that is mainly for fetal heart rate monitoring and fetal echo. And there is another concept called color Doppler. So for example, what is B mode? B mode means grayscale. That means suppose I will throw a ball to a wall at a 90-degree angle. So the ball will come back to me. Again it will come back to me, because I am throwing the ball to the wall at a 90-degree. It will come back to me. That is called B mode or grayscale. That means sound wave hit the object and it come back to a probe at a 90-degree. So if we keep our probe to an object at a 90-degree place, we will get the complete picture. So because all the waves are getting reflected from that object and coming back to the probe. But if I change the probe or move the probe to another angle, so this image will be changed here, because all the waves will not hit or not get reflected back from that object to the probe. Some will miss the object and some will not also come back to the probe, because if I will change the angle of the probe, so at different angle you will get different image on the monitor. So like that. But for color Doppler, the blood is flowing in a vessel, the blood is flowing, that is a running object. So in that case, if you throw a ball, suppose this is running train, so the train is running towards from left to right, so from right to left. In that case, if I hit the ball or throw the ball to the train or running train, then the ball will not get back to me. It will thrown beyond or outside. Similarly, if I put a probe on the blood vessel at a 90-degree, that means the sound waves will not go back to the probe again. So I will not get any image on the monitor. That means if I will put the sound wave, the sound will get reflected to another angle, so it will not come back to probe, so there is no image on the monitor. So it is based on the principle that is cos theta. So if you will put and probe at 90 degree, that is cos 90, that is 0. That means I will not get any image on the monitor. So this concept is called as angle of insonation. So best angle of insonation is if the train is running like this and I will throw the ball at an angle 15 to 30 degree, then I will get the ball again back to me. Then only I can, so if the probe is kept at an angle of 15 to 30 degree, then I will get an image on the monitor. That is the concept of color Doppler. So for color Doppler, the angle of insonation is very important. So if I am not getting an image on the monitor, that means the angle is 90 degree. Cos 90 is 0. If an angle is 0 degree, that means cos 0 is 1. So maximum value I will get. See here, this is the probe. See, this is the probe. And there are multiple vessels at different angles. For example, so this is at 30 degree. So I am getting a good image or good velocity. This is 60 degree. I am not getting that proper image. I am getting the image, but not that. Cos 90, 0. It is very minimal or very light velocity, or may not be. I will get a blank image. And if it is in opposite direction, so I will get an inverted image. So there will be an inverted button on the screen on the ultrasound monitor. So you will press that, the image will be rectified to the image will be upright. Okay, so this is the basic concept of Doppler. The main concept is angle of insonation. So why angle of insonation is important? Because it is the blood is flowing or running inside the vessel, so that I am not getting proper image if the angle of insonation is not correct. Then coming to Doppler in obstetrics. Doppler in gynecology is also a different concept. It is used in malignancies, folliculometry, and other ovarian cyst, torsion of ovarian cyst. So it's a wide, broad area. So I will discuss only Doppler in obstetrics today. In that part, see, basically we use it in 3 areas: in first trimester, second trimester, and third trimester. In first trimester, Doppler is used in uterine Doppler. I will discuss this, elaborate it later. First, I am giving the concept. Uterine Doppler is done at 11 to 14 weeks. That is during the NT scan. If I will calculate a PI means pulsatility index. If it is more than 90th centile, then it is high risk for early onset preeclampsia or FGR. We will understand it in detail later. In that case, you add aspirin 150 mg. Why? Because there is more chance of developing fetal growth restriction or early onset preeclampsia. So we add aspirin to prevent that. Next is DV Doppler. In first trimester, we also do DV Doppler, means Doctor's venosus Doppler. That is also done during the NT scan at 11 to 13 plus 6 weeks. And if we will get abnormal DV flow, that means absent or reversed AUF in DV flow, that suggests chromosomal anomalies or cardiac anomalies. Maybe the fetus has chromosomal or cardiac anomalies. Then we have to, this is just a screening. This is not a confirmatory test. This is just a screening. We will get confirmatory by amniocentesis or chorionic villus sampling. Next is, again at second trimester, we will do uterine Doppler. Uterine Doppler, that means if in uterine Doppler, normally before trophoblastic invasion, in uterine Doppler there is decreased blood flow, that is there is decreased diastolic flow. After trophoblastic invasion, the vessels become dilated, permanent state of dilation. So there is presence of absence, there should be no notching, that is increased diastolic flow or no notching in the uterine Doppler. I will show the image. So if there is persistence of notching after 22 weeks, that is associated with hypertensive delay of pregnancy and FGR. So we have to prevent that. So I will tell you how to do that. And in case of twin also, in second trimester, in case of especially monochorionic twins, we do from 16 week onwards. From 16 weeks 26 weeks, there is increased chance of developing twin transmission syndrome, selective fetal growth retardation, and TAPS, twin atrial perfusion syndrome. So in that case, we have to do MC Doppler, umbilical artery Doppler every 2 weekly in MCDA twins to diagnose TTS, SFGR, and TAPS. So that is the concept of Doppler in second trimester. Then in third trimester, we do umbilical artery Doppler, MCA Doppler, and Dr. Sonosuke Doppler mainly for FGR and cardiac compromise, and umbilical vein Doppler also. These 4 Dopplers can be done in third trimester. So coming to one by one. First, coming to the concept of umbilical artery Doppler, uterine artery Doppler. Uterine artery Doppler, listen, in the basic concept is during early pregnancy, there is a uterine artery at the internal level of the internal os. Okay, so if we first thing is why you are measuring uterine artery Doppler in first trimester and second trimester both. Why? Because there is a trophoblastic invasion during pregnancy, occurs between it starts from 12 weeks and ends by 18 weeks. What is the concept behind the trophoblastic invasion? Because the spiral artery, the hierarchy of arteries is A, R, B, S, arcuate artery, radial artery, basilar artery, and spiral artery. So the spiral artery are the end arteries supplying the decidua, and the fetus will be spiral arteries. So the smallest arteries. These spiral arteries undergo trophoblastic invasion. Why? Initially they are high resistance and low flow. They are highly resistant vessels with low flow. But after trophoblastic invasion, the fetus needs more blood, so there is changes of trophoblastic invasion occurs during this period. So they convert into a state of permanent vasodilation at 18 weeks, and they become low resistance and high flow vessels. So they become a state of permanent dilation. That means more blood can flow through them to the fetus. The fetus will get more blood as the pregnancy increases. There is a requirement of more blood. During the third trimester, a term pregnancy, by these both uterine artery, single uterine artery can there is a flow of 850 ml per minute of blood through this uterine artery per minute at term pregnancy. So this is around 1 liter of blood passes through this uterine artery in every minute. That means the concept of trophoblastic invasion arises. Why? For example, there is a 3 storage or 4 storage building, and there is a water tank here. If you open all the taps in every room in that building, there is increase of water because every tap is opened in that building. That means the water flowing through this main pipe will be increased. So can we put a Doppler on this spiral artery? No, we cannot put a Doppler on the spiral artery because there are multiple spiral arteries and they are very small arteries. So we cannot put Doppler on this. We cannot measure this blood flow in that spiral artery. So ultimately, what we'll do? The uterine artery is the bigger vessels, so we can put a Doppler here, and it can be easily accessible by probe. So we know the anatomy. We can put a probe on the uterine artery. So as this is accessible, and this flow can ultimately represent the flow in the spiral artery, because if the spiral artery or trophoblastic invasion has been occurred and there already increasing flow is occurring, that means ultimately the flow in the uterine artery will also increase. Like the main water flow in the main pipe will increase if we will open all the taps. For example, these are the spiral arteries. So it will open all the taps. That means more water will flow, and ultimately more water will flow on this main pipe. So if we will put a probe here, that means we can say that the water flow is increased in all the taps. Like that, we cannot put a probe in the spiral artery, so that we are putting that probe on the uterine artery to measure the blood flow in that spiral artery. So it is an indirect representative of the blood flow in the spiral artery, that is the uterine artery. That is the concept of doing uterine artery Doppler at first trimester and second trimester. So if there is trophoblastic invasion has been occurred, that means there is increased flow and the vessels become low resistance and high flow. Initially, if you the uterine artery Doppler looks like this. There is a systole, so this is called systole. There is a notching, and again there is a diastole. Systole, notch, and there is a diastole. But after trophoblastic invasion, gradually the flow increases and the notch disappears. So there is no notching here. There is a systole, there is a diastole, but there is no notching. That is a continuous flow because of this trophoblastic invasion, and that is called, we call it increased diastolic flow, because there is increased requirement by the fetus. So absent of notching. So after 18 weeks or in the second trimester after 18 weeks, by 22 weeks this should be completed and absent of notching should be there. If at 22 weeks we are getting this type of Doppler, that means there is some problem. That what problem? The trophoblastic invasion has not been occurred. There is a failure of trophoblastic invasion. So there will be decreased flow. Once there will be decreased flow to the fetus, that will be FGR, fetal growth restriction, and hypertensive disorder pregnancy will occur. So at 22 weeks, if notching is present, like this image, that means failure of trophoblastic invasion. So the fetus will develop FGR and gestational hypertension. Then coming to what are the parameters we use? The prediction of preeclampsia. What is the prediction? So what we will do? We'll do predict it. How we will predict the prediction of preeclampsia? There is different parameters in first trimester, second trimester, third trimester. We will discuss this later. But there is 3 parameters used: SD ratio, RI, and PI in Doppler. What is SD? SD means systole by diastole. This is the systole, this is the diastole. So systole by diastole is SD ratio. RI, what is RI? RI is resistive index. Resistive index, and PI is pulsatility index. The resistive index is S minus D, systole minus diastole by systole, and pulsatility index is systole minus diastole by mean. That is, mean is S plus D by 2. So this is pulsatility index. Why you are measuring it? For example, suppose, and this pulsatility index or resistive index, they have a particular value for gestational age, and there is a chart that is called percentile chart. So if it comes beyond more than 90th centile, then we can say it is high risk for gestational hypertension and preeclampsia. So, and its detection rate is 48%. So we'll add aspirin 150 mg, low dose aspirin. Low dose aspirin means 150 mg before 13 weeks, before 12 weeks, and continue till 36 weeks of pregnancy. So this is all about uterine artery Doppler and the use of uterine artery Doppler in first trimester pregnancy. Okay, then coming to umbilical artery Doppler. Why we are doing umbilical artery Doppler? First, understand the concept. See, initially there is fetal hypoxia. Suppose for there is any third trimester, there is fetal hypoxia or fetal distress, and there will be oxygen supply, decreased oxygen supply to the myocardium. So there will be stiffening of the myocardium. The myocardium will be stiffened. So can it pump adequately or not? It cannot pump adequately. So the cardiac output will gradually diminish. Once cardiac output is diminished, the whole blood, the every amount of blood coming into the heart, it will accumulate inside the ventricle. So accumulation of blood in the ventricle, because heart is going to be, heart is not able to pump. So all the blood coming into the heart is getting accumulated inside the heart. So the ventricle will ultimately get dilated. So we call it atrioventricular ring. The ring will get dilated. So that is called, so there will be ultimately, if the atrioventricular ring will be dilated, that means the ring will be initially dilated. It is like this, and there is a tricuspid valve. If because of the accumulation, the heart becomes like this, and the ring is getting dilated, but the valve is only this much. So valve cannot resist all the blood, so there will be regurgitation, that is called tricuspid regurgitation. So once there is tricuspid regurgitation, here is the, suppose this is the ventricle and this is the aorta. So because of tricuspid regurgitation, all blood go into atrium, right atrium and left atrium. From the right atrium, all the blood IVC and SVC. So the flow will be, suppose there is all the blood is accumulated in the ventricle. Blood cannot go forward, so blood has to go backwards. Because of the accumulation of blood cannot go forward. So blood is gradually accumulated in the atrium or right atrium, then in the IVC. So IVC will be congested. Then what will happen? So there will be, once there is congestion of IVC, there will be reversal flow in the IVC. IVC is connected to ductus venosus. So there will be reversal of A wave in the ductus venosus, and it is connected to umbilical vein. So there is pulsation in the umbilical vein. And another important thing, as the cardiac output is decreased, so cardiac output is decreased, that means there is umbilical artery, the flow in the umbilical artery will decrease. How? I am telling that again the concept by image. See, this is the heart. In case of hypoxia, the myocardium gets stiffened. So myocardium is weak now and it cannot pump all the blood into the body, so it got stiffened and it cannot pump. So there will be decreased cardiac output in the body, fetal body. So decrease of cardiac output. So this is the abdominal aorta. The abdominal aorta divided into right common iliac artery and left common iliac artery. Again it divided into external iliac artery and internal iliac artery. From the internal artery, there is a branch, that is umbilical artery. So these are the two umbilical arteries. Once the cardiac output decreased in the aorta, it will decrease here, decreased here, ultimately in umbilical artery also the flow decreased. That's why we are measuring umbilical artery Doppler. We are doing color Doppler of the umbilical artery, because the output of the heart is it is indirectly represented in the umbilical artery. That means umbilical artery flow is diminished. That means the cardiac output is also falling. So there is initial phase of cardiac compromise, that is fetal distress. So umbilical artery. So initially there will be decreased diastolic flow. So and gradually there will be absent diastolic flow, and ultimately there will be a reverse diastolic flow will occur. So blood will not go here, and the blood will be, during the diastole, blood will revert back, because cardiac output is not adequate. Again, once the blood is accumulated inside the ventricle, so the atrioventricular ring is expanded. So tricuspid valve cannot keep all the blood here. So the blood coming from supravena cava, infravena cava to right atrium and right atrium to right ventricle, it cannot go forward. So because it is right ventricle is already filled, now the blood has to go back, because there is a traffic jam, so blood has to go back. So it will be, there will be backflow flow into IVC. From the IVC, there is a ductus venosus. So ultimately there will be reversal of flow. So we will tell it reversal of A wave, because there is backflow occurring. Why there is backflow? Because right ventricle is failing. So if there is reversal of A wave, in that is an indicator that right ventricle is failing. That is a sign of cardiac compromise. Once there is a reversal of A wave, ultimately there will be pulsation will be seen, because that pulsation, right atrium pulsation, will be transmitted from here to the umbilical vein. So there will be pulsation will be seen in the umbilical vein. If pulsation is seen in the umbilical vein, that is a sign of imminent cardiac compromise. So this is the basic concept why we do all these Dopplers, all umbilical artery Dopplers, ductus venosus Dopplers, and umbilical vein Doppler and uterine Doppler. This is the basic concept behind this Doppler. Now we will interpret these Dopplers. See, during the first trimester, see, there is a notch. This is the systole. See, this is systole. This whole thing is systole. This is the notch, and this is the diastole. So this is the urinary flow. Gradually, in second trimester, as because of trophoblastic invasion, the notch is now absent. Notch is completely abolished. So this is the systole, and diastolic flow has been increased. So SD ratio will decrease. Why decrease? See, if you can interpret a graph, then you can easily tell what will be the value of SD and PI and RI. So what about RI and PI? So just tell me, if diastole is increasing, the denominator is increasing, that means SD ratio value will be decreased. Yes, okay, that means that is normal. For example, if diastole value will be decreased, SD ratio, the diastole is decreasing, that means numerator will be high, denominator is low, so SD ratio will be high. If SD ratio is high, that means this is not good sign. So SD ratio should be low. Similarly, for goes with RI and PI. RI is S minus D by S. If diastole is increased, so final S minus D value will be low. So RI will also decreased. Similar goes with PI also, S minus D by mean. So if diastole is decreasing, so diastole is increasing, that means S minus D value will be also low. So ultimately PI value will be less. So for urinary Doppler and umbilical artery also Doppler, this concept goes right. That means SD ratio will be decreased as pregnancy increases. There is increased blood flow. So through the spiral artery, through the urinary artery, that's why the SD ratio will decrease, PI will decrease, and RI will decrease for umbilical artery and for urinary artery. See, in the third trimester, urinary artery, there is very much diastolic, more diastolic flow, and SD ratio will decrease, PI will decrease, RI will decrease. Okay, next coming to, so see, this in umbilical artery. So before, in first trimester also, there is less flow, there is less blood flow in the umbilical artery. So the amplitude will be less. But in second trimester and in the third trimester, there is increased diastolic flow. Diastolic flow is increased. And the third trimester. So tell me, in third trimester, what about SD ratio regarding with respect to first trimester and second trimester? So SD ratio will decrease because diastolic flow has increased compared to the second trimester and first trimester. So RI and PI both will decrease. For umbilical artery, remember, after 32 weeks, SD ratio should be less than 2 and RI/PI should be less than 1. It should be decreased less than 1. The particular value will be represented in the percentile chart. So we compare with the percentile chart. If it is more than 95 percentile PI or RI, then it is a sign of fetal distress. Okay, see how we interpret it. So there is a concept of, so now tell me, this is the normal umbilical artery Doppler. See the diastolic flow, this is the systolic flow. If the diastolic flow has been decreased, that means the cardiac output has been decreased. It's a sign of fetal distress. So because of increased resistance. So tell me here, PI and RI. What about PI and RI and SD? Diastole is decreased, so SD by D ratio, D is decreased, so SD ratio is increased, so SD ratio will be increased. What about PI and RI? PI and RI. PI, that is S minus D by mean, so diastolic is decreased, so S minus D value will be increased, so PI value will be increased. So if PI is increasing, SD is increasing, and RI value will be increasing, that means that is a sign of increased resistance in the fetal umbilical artery, or that is decreased cardiac output, that means fetal distress. Then in case of absent diastolic flow, so S minus D, D is 0, absent, so S by 0, so SD will be infinite. Okay. In case of reverse diastolic flow, so see, there is no diastolic flow here, that is absent diastolic flow. Here this is absent diastolic flow and this is reverse diastolic flow. That means the diastolic flow has been reversed. That means there is backflow is occurring. I have told in case of cardiac compromise or cardiac failure, because there is diastolic flow is not occurring because cardiac output is not adequate, so there will be reversed end-diastolic flow. So when to terminate this patient or how to manage this patient, this is the FIGO guideline. What FIGO says, see, FGR with mild abnormalities, like if the umbilical artery PI is more than 95 percentile, that means this is more than umbilical artery PI is only increased 95 percentile, that means there is reduced end-diastolic flow. Then or MCA PI, MCA is middle cerebral artery, or CPR is less than 5. Then admit inpatient monitoring, consider steroid for lung maturity, BPP or NST every 1 to 2 times per week, and do Doppler 1 to 2 times per week, every 2 to 3 days, and growth scan every 2 weeks, and deliver by 34 to 37 weeks. Mode of delivery is cesarean section or induction. So for reduced diastolic flow, that is reduced diastolic flow means that is indirectly PI, uterine artery PI is more than 95 percentile. Sorry, umbilical artery PI. For absent or reversed end-diastolic flow, the overall risk of stillbirth in case of absent is 6.8%. This is a question, and reversed is 19%. So the median time of deterioration will be, for absent it is 5 days, for reversed it is 2 days. So admit the patient, give steroid, BPP NST 1 to 2 times per week, and Doppler every 1 to 2 days, daily Doppler or alternative Doppler, and growth is every 2 weeks. For absent, deliver by 30 to 34 weeks. For reversed, deliver by 30 to 32 weeks. So mode of delivery is cesarean section. And then the next step is abnormal ductus venosus Doppler. I will discuss the ductus venosus Doppler here. Before that, let's discuss about MCA Doppler. Middle